Bismillahirrahmanirrahim. So we have started the diseases of the thyroid gland, and as I discussed in the previous video, hyperthyroidism. So I discussed that the primary cause of the hyperthyroidism was Graves' disease. In 99% cases, hyperthyroidism is due to Graves' disease. In 1% cases, it is due to the secondary cases like pituitary adenoma and Hashimoto thyroiditis, autoimmunes, other autoimmune disorders. In Graves' disease, it having diffuse goiter, as well as in Graves' disease is like a syndrome. It have the hyperthyroidism, exophthalmos or proptosis, and dermopathy on the lower extremities. So exophthalmos or proptosis is the same, in which the extrusion of the eyeball occurs. It is due to the swelling of inferior rectus muscle. So when the inferior rectus muscle swells, so the eyeball get out interior sides. In the Graves' disease, there will be the secretion of the thyroid-stimulating immunoglobulins antibodies, which attach to the receptors of the thyroid gland to the receptor of the thyroid-stimulating hormone and stimulate the thyroid gland to secrete more and more T3 and T4. So it affects the people less than 50 years and mostly occurs in women greater than men. Significant genetic component, it means that if someone have a family history of thyroid disease or Graves' disease or hyperthyroidism, so then the siblings or the relatives also have chances of Graves' disease. Other autoimmune diseases like type 1 diabetes and pernicious anemia, if someone have these diseases, so there is increase the chances of the Graves' disease, because Graves' disease is also autoimmune disorders. And when someone have Graves' disease and he is also smoking, so it increase exophthalmos more and more worse the condition of the protrusion of the eyeball. So all was these about the Graves' disease. That what is the Graves' disease? Graves' disease is the primary cause, and how we will differentiate the Graves' disease. So it is actually a syndrome of hyperthyroidism, exophthalmos, and dermopathy at the lower extremities, as well as the thyroid-stimulating immunoglobulin secretion. So all these indicates the Graves' disease in a patient. Then there are some clinical features in the Graves' disease. Mostly this will be the clinical features of the hyperthyroidism, but as we are discussing that 99% causes of the hyperthyroidism is Graves' disease, so these clinical features will be for hyperthyroidism as well as for Graves' disease. So there will be nervous symptoms in the younger patients, nervous symptom, because there will be symptomatic and nervous symptoms, as well as severe symptoms. And the severe symptoms mostly arterial fibrillation because of the sympathomimetics activation, like the beta 1 activation. So there will be heart rate increases, and beta 2 activation as well as alpha 1 activation, so it will increase the hypertension. So all these is due to the overstimulation of the sympathetic system. So there will be hypertension, heart rate increases, tremors due to beta 2 stimulation, tremors and palpitation, and due to alpha 1 stimulation the patient will have hypertension, because alpha 1 constrict the blood vessels. So that's why. Inability to sleep, the patient with the Graves' disease will have inability to sleep, insomnia, frequent bowel movement, excessive sweating, hyperhidrosis. He mostly in the feet, in the palms, he will carry tissue paper with him, because he will feel ashamed while meeting someone or head shaking with someone. That will be the excessive sweating. This is called hyperhidrosis. Heat intolerance, he can't endure the heat. Ocular staring, like he will be looking like staring on someone, and infrequent blinking of the eyelid. Sleeping pulse rate. This is the most clinical feature or examination point which we using. Mostly we are checking the pulse rate on a vacant state, but here we will check sleeping pulse rate. It is also called sleeping tachycardia. Sleeping tachycardia. We are checking this because we want to differentiate this person from type 1 personality. It is a psychotic disorder personality which have all these symptoms, the CVS and the nervous system, but he will not have sleeping pulse rate high. But in this grave disease, the patient will have sleeping pulse rate high because of the excessive T3 secretion. There will be menstrual irregularities like oligomenorrhea, etc. So all these were the clinical symptoms which we will find in the patient of hyperthyroidism or grave disease. In the diagnosis, we will mostly check thyroid-stimulating hormone. If the TSH is low, so it means that the patient have a problem in the thyroid gland. So if the TSH is low, so then we will go for thyroid-stimulating immunoglobulins. But if TSH is high, elevated, then we will go for MRI of the head and head scan. Then we will go for MRI of the head scan. Then we will not check thyroid stimulating immunoglobulin. After the TSH confirmation, we will check total T4 and T3. Thyroid TBG, thyroid binding globulins, as we know, and TSI for as indicated in the grave disease. We will checking for, if the TSH is low, then we will go to TSI checking. After that, we will have symptomatic treatment. We will symptomatically treatment like inability to sleep, arterial fibrillation, antiarrhythmic drugs we can give, and then we will give firstly propranolol, beta 1 antagonist or beta blockers. We will use propylthiouracil PTU, propylthiouracil in first trimester and breastfeeding. So as I use the word first trimester and breastfeeding, I skip the second trimester and third trimester. Why? Because the propylthiouracil when we used initially, so it is surrounded by the highly protein which can't cross the placenta, and if we are using it for a long duration, so then it cross the placenta. That's why we are using early in the first trimester. In the pregnancy, then we switch into methimazole. Methimazole has less side effects, and we are using in the pregnancy according to the new rules. And then we are using the radiation. We are using radioactive iodine 131 and 123 we are using for shrinkage. And then finally we have to do total thyroidectomy. This is a surgery if we have problem in the thyroid gland. But if we have problem in the anterior pituitary, so then we will use transpenital surgery. So all these was about the thyroid gland. Because we are discussing the internal diseases, so mostly we have to focus on the diagnosis, treatment, clinical features, and little bit we are not going to the pathophysiology and the physiology and anatomy, because mostly we need how to diagnose, how to differentiate, and what are the differential diagnosis in these cases. So that's all about the grave disease. Thank you so much. Like, share, and comment.